And at the outset, I'd like to thank Department of ENT FMC Pune for this opportunity. It's my first time here at AFMC, and I'm enjoying my presence here. And I'm just enjoying. It's a great feeling just moving around in this campus. So again, the theme of this conference is again very interesting, and on one that is going to be probably part of our routine practice in the years to come. And my topic is on role of AI in navigation systems and endoscopic surgery. So at Tata Memorial Hospital, we have a skull-based clinic, and we do deal with skull-based surgery. It was initially initiated by Dr. Pratmesh Pai, and now it's being taken forward by Dr. Deepa Nair, myself, and we have a good team of neurosurgeons, Dr. Ali Asgar, Dr. Prakash, and Dr. Vikas. So there was a talk in the morning that the ENT surgeons and the neurosurgeons should collaborate and work in tandem in treating patients. And this is one area where at the Tata Memorial Hospital, we really work in tandem and we see wonderful results. So as part of that, the topic is role of AI in navigation systems and endoscopic surgery. And we do use navigation system in our cases. And the use of tracking technology and navigation systems have revolutionized the endoscopic skull-based surgery per se. And the role of navigation system is to enhance the surgeon's knowledge of anatomy and expertise in that field, and not to replace it. That has to be the basic bottom line that we need to understand. And most common navigation system used is the optical or the electromagnetic tracking systems. Both have their pros and cons, which we'll just see in a couple of minutes. And these navigation systems essentially allows us to, have information on bony landmarks, position and size of any lesion, as well as the location of critical structures in and around the area that we are working, because the skull base, we all know, is overcrowded with important structures. And the current registration accuracy of these navigation systems are at 2 millimeters. And these are some of the commonly used anatomical landmarks in the endoscopic surgeries within the lateral nasal wall. And these are important to create corridors when you're going to do expanded endonasal procedures. And now the two types of navigation systems that we're talking about, the electromagnetic and the optical, both have their own pluses and minuses. Electromagnetic systems, they can be used, once it's set, the registration is done, the patient's position can be changed, and that is important while doing a skull-based procedure. But then you cannot use it in patients having a pacemaker or, anything of that sort. Whereas the optical system is much easier to use, but it needs, once you set that position, you cannot change during the procedure. So that registration might change and you will not get an accurate navigation during the procedure. So at Tata Memorial, we use both the systems. The one on the left is the electromagnetic, where we are doing the registration before the initiation of the surgery. And it takes some time before we, as we do the registration. So that takes a good amount of time. And the other one is the optical system, which probably takes lesser time and it is more easier to do. So these are the registration. Once it is done, as you're using the navigation during the procedure, these are some of the pictures that you get in these two systems. Now, these navigation systems are a must when we are dealing with tumors such as this. We do get a lot of angiofibromas, which are far way too advanced, such as this. And many times these cannot be done without navigation system. It would be a risky procedure to do an angiofibroma such as this without navigation. And another case wherein you have the extension of the angiofibroma within the cavernous sinus and at the loop of the internal carotid artery within the cavernous sinus. So you need to know where you are while you are operating, and that's where the navigation system comes into play. Again, petroclival lesions, we'll have a small video on this petroclival lesion as to how the navigation system is used and how I feel the AI can help in the future if we have AI integrated into the navigation system as a small video subsequently. Now here, this lesion is exactly in the petroclival region, just behind the internal carotid artery, in the petrous part of the internal carotid artery. And it is very helpful in cases of craniopharyngiomas and pituitary tumors, adenomas such as this, wherein you have one internal carotid artery which is totally encased and it has a lateral component, and you really need to know where you're, where you're working once you've gone into the cellular region. So far, the conventional navigation relies basically on static preoperative images, which may not accurately represent intraoperative changes, such as tissue deformation, removal, or brain shift while you're doing while the procedure is being done. In endoscopic procedures, factors specific to individual surgeons and patient influence the navigation process that we are aware of. Currently, however, there's lack of the ability to predict the operator's future action and potential pathways. Now, when you're creating corridors and when you're going through structures, you are at times not sure as to where you're heading to and what would be the surgeon's next step. So if you're a bit unsure, you might, end up damaging certain critical structures. And this is where I feel the AI integrated into the navigation system might be of use. And the new navigation systems, there are certain new navigation systems that are available wherein they employ an image-based approach for the registration of images and detection of objects. And also it can be integrated within your endoscopic view as well. So that is the latest that we have. Went to the end. Yeah, I wanted to welcome you all there, but I think that was a bit too premature. Okay. Now, essentially, using navigation is like using the the GPRS while you're traveling in a car. To look at where you are and how do you go take a right or a left. Presently, the navigation system that we use in endoscopic sinus surgery does not tell you that. It tells you where you are. It does not tell you where to go next. So that is where AI will be useful as we proceed. And that is where the artificial intelligence and deep learning methodologies will help us take this navigation system a bit ahead. And in this way, the surgical goals and also it can tell us which instruments can be used there and what are the structures based on the haptic feedback of that structure that you are working nearby. And the predictive information on the navigation process may also improve the ability to, tell you how much more time the procedure will take. It will give you a sense of what is the duration of surgery that would be needed henceforth. And of course, there's no saying no doubting that this will help us minimize complications, and optimal surgical pathway and even predicting the ideal instruments would help us in achieving all of this that we just mentioned. Now, this is just one endoscopic wayfinding assistance using one of these deep learning methodologies, wherein you can see this is an endoscopic view. The authors of this article have used the deep learning methodologies, wherein they're saying what is their current landmark, and it will say once you are beyond this landmark, what will be the next position? That is, where do you go next? Like how you use it in the GPRS. So probably that is what is going to happen in the years to come. But again, as it has been said since morning, it all depends on what information we feed. What are the images that we feed into the system for it to tell us as to, to make the system much more useful. So it's very important and essential that we give the right information to get that right output. And also, the other aspect is the AI-generated 3D reconstructions of skull base anatomy and augmented reality. I just come to that. And it helps us understand as to what is the position of the tumor in relation to critical structures. And you can probably manipulate and see and navigate and understand as to how your surgical steps should be while approaching those tumors. And this ensures precise and accurate surgical maneuvering during the procedure. Some of the other uses of AI in navigation endoscopic surgeries are the AI algorithms analyzes intraoperative images and data to provide dynamic guidance throughout the surgery, as mentioned. And AI-based navigation can provide the advantage of real-time adaptation, as to if you're closer to a structure, that, and it's saying it's critical, you can just move away from that structure. Many times when you're working in the cellular region, you are not sure as to what is the distance between the two internal carotid arteries. So you use endoscopic ultrasound. So maybe the navigation can have this inbuilt technology which can tell you that how close you are to these structures so that you can just stay away from them. And it can continuously analyze the intraoperative images and keep giving us real-time feedbacks. And this helps us, adapt and carry out precise surgeries, minimizing the risks. And the AI should also alert as to if we are closer to a structure, as I've been mentioning, to just work away from a certain critical structure or of that sort, so that we can minimize complications. And also, if a certain tissue is being handled a bit too much, it should sensitize us about that aspect, and I know it can enable us to take corrective measures at a timely manner. And the other possible applications that are there is that some of the authors have used it to predict as to accurately determine the metabolic profile of the resected specimen, and by that they were able to achieve a good clearance in terms of getting a good margin when the tumor is intracranial. And also, based on certain convolutional neural technology, a much more sophisticated technology, they were able to predict the extent to which a tumor resection should proceed in endoscopic transnasal surgery with a good accuracy rate, and thereby preventing damage to critical structures such as the optic nerve or the carotid artery. And at times when you're dealing with tumors such as craniopharyngiomas, you have to displace the pituitary lower down, and you have to work in the region which is above the pituitary. And when you're trying to save the pituitary, if the pituitary stalk is damaged, then there'll be problems. There'll be a lot of hormonal issues in the post-op. So all these information can be garnered during the procedure with the help of AI. And this is one of the latest article published in Lancet, which talks about various randomized trials evaluating artificial intelligence in clinical practice. It was a scoping review. It talks about where AI was used across various medical disciplines, and it was all these were coming predominantly from the US and and from China. And the predominant specialty that has been using it is gastroenterology and radiology. So, and in oncology, it's not been implicated as much as what it has been, tested in various other specialities. So the idea of putting this up is to tell that there's a lot of work going on in AI, and maybe in the years to come, it will be one of the things that we'll probably be dealing with on a routine basis. And this is is it playing? This is a small video wherein we used, okay, yeah, it's playing. Thank you. So where we used navigation at very well, and where I think AI can be of use. This was a petroclival lesion, as you can see here. Do you have a pointer? Right, and that we had the petroclival lesion here. That is the lesion, and we had both CT and MRI, which was integrated into the navigation system, and we used it throughout the procedure. And here we had reconstructed the images, and that is the internal carotid artery, and this is the tumor just lying behind the internal carotid artery as it's going through the petrous apex, as you can see in this image. Now, the task was to go beyond the internal carotid artery and get a biopsy. The radiological impression was that it's not a chordoma, it could be a chondrosarcoma, but we need to have a biopsy before giving radiotherapy for these patients. Now, that is the landmark which you just saw, and we are just trying to create the corridors to reach this aspect. So as you saw in that image, you saw what structures were there. So this is where AI can actually tell us what are the structures in and around that are there. And as you're drilling to gain access, it can probably sometimes the rostrum can be attached to the internal carotid artery, the bony wall, and that maneuver is not advisable. So all these things can be alerted by the AI system. And this is the Vidian nerve, and we just trying to establish go towards the internal carotid artery that is there, the internal Vidian nerve, and that's the clival recess and the cellar. So we just have to work in this area to reach the petrous apex and to get the biopsy. We aimed at getting a biopsy, but I'll tell you what we ended up achieving. So we're just trying to work, keeping the Vidian nerve as the landmark, and we're just trying to drill that region and slowly trying to create a small opening into the petrous apex region. So here now we have drilled, this is the clival area, this is the floor of the sphenoid. We're almost into that's the nasopharyngeal mucosa there. So we just drilled out the entire floor of the sphenoid, and we're just trying to go closer to the petrous apex area here. So it's very essential that we, of course, are oriented to the anatomy of this area. But then if you have and we use the navigation system throughout this procedure to just make sure where we are. But if you use AI as a real-time situation, it should keep telling us where we are so that we will try to be away from the internal carotid artery and various other structures. So that's the internal carotid artery here, and the clival area region, that is the Vidian nerve. We're just trying to open that up. And we're doing this in tandem with our neurosurgeon. So once we open this up, the neurosurgeon, is there with us. And it's a forehand technique. And the head and neck surgeon and the neurosurgeon work in tandem and trying to get this tumor out. So now as we are drilling here, we need to be careful that we shouldn't go way too lateral, because if we go there, you hit your internal carotid artery there. And now we are just opening up that region and you see the tumor there. So that you're thinking it's a tumor, it could be something else. So that's where the AI should be able to tell us as to what it is, whether is it a tumor or is it any other critical structure that is there. So we just have to keep opening that up, and and this is a case which I strongly feel that AI will be of great help. And though our anatomical knowledge is very, very important, but at times when you're working in such area, you're really a bit unsure. You're using navigation, but still you're a bit unsure. And a case such as this with, if to be done without navigation is going to be a bit of a gamble. So a navigation system to do this case is, again, I need to impress upon the fact that is very, very essential. So creating that corridor to reach the petroclival region is the crux of this situation here. So we have just created that opening. Now we need to widen that opening within whatever permissible area that we can do that. And once that is done, we need to get a biopsy. And we were just, once we were reaching the tumor and getting more access, we were getting more ambitious. We were trying to get a gross total resection. So in neurosurgery, the tumors are of two types. Either it's a suckable tumor or non-suckable tumor. That's what our neurosurgeons always say. So this looked like a suckable tumor. So once you took the biopsy for the histopathological diagnosis, so our neurosurgeons most of the time suck out the tumor, right? And here you cannot aim to achieve a margin. All you can do is to get a gross total resection, which is what we ended up getting in this case at the end of it. So here we need to be careful. So that is the posterior fossa dura. So you need to be sure. You need to identify that is your limitation and you shouldn't go beyond that. And if there's a leak here, then you will have a high pressure leak and it's going to be difficult to manage. So these are the feedback that the AI can be giving us during the procedure. And if you go way too laterally, you have the intercavernous sinuses, which will again start bleeding. So there are a lot of critical structures around which you need to be careful and just get the tumor out as much as possible. The thing is, this patient presented with a sixth nerve palsy. That was his presenting complaint. So we tried to decompress it as much as possible. And fortunately for us, is the patient in the post-operative period had the sixth nerve palsy was minimized to a great extent, and over the days it was totally not there, because the tumor could be totally could be removed. The gross total resection was achieved. So that's the posterior dura here. You can just see the entire dura going down there. This is the entire petrous apex region here, and we are just sucking out the tumor that is there in the region here. So you see the posterior fossa dura along the entire extent here, and we're just sucking out the tumor. And it was difficult for us to drill anything here because we didn't have the instruments with those angulations, and it's difficult to drill. And we should never, and we were very particular to not pull out anything, that will be catastrophic. So all that we could do was suck out the tumor that we could do as much as possible. So we just removed almost all the tumor, and we could end up having a fair gross total resection at the end of it. So that's the entire tumor cavity, and probably that's the entire petrous apex area, and that's the posterior fossa dura that you have here. And so we made sure that this was one bony ledge that was almost hanging freely, but then we didn't want to pull it out because you had the internal carotid artery just there. So we just controlled ourselves not to do anything silly at this point in time. So once we removed as much tumor as we thought was possible, and we couldn't see much more, at least in this area, and this is where again AI can help us tell as to whether there's any residual disease that is there at the end of the procedure. And then there was no leak, which was identified, which was confirmed with the Valsalva. We just packed it with fat, and the sphenoid sinus mucosa itself was used to, close at the end of it. And this is just fat that is there in the post-operative cavity. And you can see in the CT scan, it's seen much better. You can see the CT scan, this is the entire area that was drilled out, and we could achieve most of it. And it came as chondrosarcoma grade 2, and the patient is currently being planned for a, proton therapy subsequently. So to conclude, I would say that it appears that AI may have an important role in navigation-assisted endoscopic surgery, especially skull-based surgery. A real-time AI-based navigation offers adaptive guidance, enhancing surgical accuracy and safety. We could expect to see more of this in the years to come. And there is a need for ongoing collaboration, data sharing, ensuring quality data, and upholding stringent ethical considerations to make this technology more useful and meaningful. I'd like to thank you for your attention and welcome you all for FHNO 2024, which is to be held in Mumbai in the month of October. So I'd request you all to register for this as well. Thank you for your attention.